All right, everybody, this is Dr. Kachikian from the Black Hills Regional Eye Institute, and this is just a little bit of a different case. You can tell this patient has had RK, and RK is interesting because um, traditionally you'll get this persistent flattening, but in certain patients you will get more of a keratoconus-like picture if the cornea is sufficiently weak focally. Then the RK can become like a cone compared to just a progressive flattening, and that's what this patient has. This patient has kind of a post-RK ectasia appearance. And you can almost see that in the light reflection in the cornea and the bulging where that astigmatic relaxing cut is. So we're going to do cataract surgery in this patient. And this patient did not want a corneal transplant. They did not want any sort of alternative procedures such as like ring segments or partial transplant or cross-linking or things of this nature. They really just wanted their cataract out because that's what they're having done in the other eye. And so one thing I was able to kind of discuss with them is placing the IC-8 Apthera lens, which kind of gives this little pinhole effect. Traditionally, it's used for improving near vision, kind of like a mini monovision in one eye, so that you can get a little more extended depth of focus while retaining some near vision, not lose total distance, but also it can be used to reduce kind of distortion in certain patients with irregular corneas, and so that's what we're doing in this case. So we're going to do our capsulorhexis, and it's taking a few. I want to get it nice and round because of this type of lens. I want that pinhole centered, so we're taking our time getting a capsulorhexis here. It looks like also having a difficult time grasping the edge. Nevertheless, we got it done, and it looks like a pretty round capsulorhexis. We are going to hydrodelineate and hydrodissect and make sure that lens spins freely in the bag. One day I should show a case of what we tend to do when the lens doesn't spin, but nevertheless usually try and get some good rotation. It helps free up some of the cortex, epinucleus, and epinuclear material, and then it allows us to access all the quadrants of the lens. So reinflate with viscoelastic, check our flow, and then I usually do a central trench. Let's clear up some of that anterior epinuclear material, do a quick trench, and then this lens looks like it's going to break pretty easily. You can see it's getting kind of clear, less irregularity at the base of that trench. And then one thing I like to do is actually see how much lens is left after I've cracked. How far did I actually get based on how deep I thought I was. I do that from time to time just to get an idea so I can see how far I actually was compared to what I thought. Now that first quadrant didn't come, and so then you just move immediately to the next quadrant. There's no sense in trying to force it out. You could spend a few minutes doing that, but it's really not worth it, especially when the lens is of this consistency. You'll just take them out gently. I do tend to kind of wiggle the tip of the phaco probe. I think that gets pieces in more quickly. This is a very deep eye, so as I watch this, I feel like I'm a little more anterior than I usually would compared to where the iris in the bag is, but at the same time, in this particular eye, the AC is very deep because it's got this ectatic appearance to it. Okay, so keep that in mind. I do tend to gently take out the phaco probe in these deep eyes. Now, to bring attention to that, this patient, RK, high axial length, there's two things you can do to prevent shallowing of the anterior chamber. One is reinflate viscoelastic prior to removing your phaco probe. Second thing that I do, if it doesn't look like there's a lot of posterior pressure, sometimes I'll just take my second instrument out, put it on the incision as I pull out the phaco probe to put some pressure on the incision and minimize any fluid egress as that phaco probe comes out. And that, if you go back and look at that, that's what I did there. I used that second instrument to push on the lip of the incision to minimize any fluid loss as that phaco probe was removed. That prevents shallowing of the anterior chamber and prevents any tension on the vitreous and any precipitation of like a retinal tear or something of that nature. And again, very slowly there. There's not a lot of posterior pressure. We will power wash the capsule. And then fill with Provisc and we will then load our lens, and you'll get to see the lens as I load it. This is the first time I put one of these in, and so I loaded that one myself. I will almost put in any lens through any injector because I feel like I have a pretty good sense of how the lens should fold and where the forces on the optic should be. And if it doesn't look like it's proceeding properly, then you just don't inject the lens. But I think we used the manufacturer's injector in this case, and it's just very similar to like an Alcon injection system. And as you know, kind of what you do in these cases, you fill the cartridge with some Provisc, then you fold the lens. Oh, here's taking the lens out. There we go. So get the lens out, try minimally, don't touch the optic. You can see that pinhole there. There are specific instructions on how to YAG these patients. And the cartridge has already been filled with Provisc, so we're going to fold the top one over, and then put the trailing haptic over the top of that. Push it in, being careful. Try not to touch the optic, and try and get that trailing haptic tucked properly. And if it's folded right, then usually there's not a lot of pressure. If you're injecting a lens and you're feeling a lot of resistance as you push it down, push it through the cartridge, then that's not how it should be. Here we're just trying to make sure it's folded in a normal taco formation. There we go, just a gentle push, and it was going to slide down through the cartridge and into the eye. Again, this is a new injection system that I really haven't used previously, so let's see how that works. There we go. There's the plunger. Just gently pushing. It's a little out of the screen, but I'm watching the plunger push on the optic and the lens just to make sure that it's folding properly. There's not any scratching or undue forces going on there. And it looks like it's taking me a minute just to kind of figure it out. Sometimes it's easy under the scope, sometimes it's harder. There we go. So that's folded nicely. The plunger is pushing on the edge of the optic. That's perfect. That's exactly what we want. It's not going over or under. We get into the incision. In this particular case, the fact that the patient has RK is really only important because, or from the ectasia standpoint, there's really not any issues with incisions, making your incisions, those sorts of things. So we'll get the lens in there. It looks like the cartridge wasn't completely in the incision when I was injecting. Nevertheless, we get the lens in there gently. It's unfolding nicely. We'll get it in the capsule bag, and then we want to make sure that that pinhole is completely centered. So don't forget to always go behind the lens to get out any viscoelastics that's there. Okay. And then because the AC is so deep, you'll have to do a pretty good job of removing viscoelastic, one from the angle and then two from essentially there right up against the cornea. You can actually see with the reflections how that one incision next to the RK incision is probably causing some of that distortion and bulging. I suppose there could be a case to be made of whether you could reopen and suture that relaxing incision to try and reduce the amount of astigmatism this patient has. That's a discussion that maybe you could have that I'd have to look at the topography to really be sure if that's a possibility. But you can see where that relaxing incision is. There's some kind of bulging. And depending on how much thinning is there, you could argue reopening that relaxing incision, suturing it down, um, and maybe that would round out the cornea. Okay, so that's a thought. Nevertheless, we've got our IC-8 lens centered. That should provide some improved vision because the cataract's out and maybe some pinhole uh, technique as well.